Hey guys, Hannah here. This is the first time we've done a podcast episode in a hot minute here. I just want to give a little disclaimer that I'm still using my two microphones. We have recently expanded, however, we are still having technical difficulties with that. So if you hear a little bit of fading in and out, if you hear someone muted for a little bit, I do apologize for that. You might also hear my dogs barking upstairs. But you guys know that comes with the territory. But having said that, hope you enjoy this episode of Weird Side Podcast.
You can't run, you can't hide. Take a walk on the weird side, it goes bump in the night. Take a walk on the weird side. You can't trust the living, you can't kill the dead. You can't stop the voices inside your head. You can't run, you can't hide. Take a walk on the weird side.
Well, welcome back, Weirdos. Man, it has been a hot minute since we have done an episode. Although we may have been gone for a long time, we weren't gone forever. We just had to take us a little break. But today we have a very interesting topic on the show to talk about. You know, it's funny, you hear a lot of people talk about adult mental health and mental health in the adult population. But when do we ever hear people talk about pediatric or adolescent health? And that's exactly what we're going to be talking about today, which I'm very excited for. On the show today, we have my good friend and coworker, Miss Alexis, who is a mental health clinician. Is that correct? Mm-hmm. We also have Renee, which is AKA my mom, and we have Miss Megan. They are both students in the Giles nursing program, and they are doing a project focusing in on pediatric and adolescent mental health. So we are very glad to have them on the show today.
Well, thank you, Hannah.
Of course. Now, before we get into the topic itself, though, I want to go and explore everyone's background, hear about everybody, and why pediatric mental health means something to you or how it's personable to you.
Thanks, Hannah. So like she said, my name is Alexis, and I'm actually a licensed professional counselor. But before that, I was once upon a time something called a qualified mental health professional, or a QMHP, which is a bachelor's level clinician. And when I was a QMHP, I did home-based counseling for children and adolescents, doing applied behavior analysis, ABA, intensive in-home, IIH, and then mental health skill building, or MHSB. And so working with children and adolescents and their families in the home is something that touched me not only professionally, but personally, and really demonstrated the need for, like Hannah said, more conversations around pediatric mental health. So excited to share this space with you all today and do just that.
I'm so glad you could be on the show, but I did have to ask you, now that you mentioned that, did you ever do anything, you know how sometimes, like, for example, I know a friend who had a son one time who was having I'm not really sure what it was, but it was like a mental health crisis, and he was very young. Did you ever participate in anything like that, like emergency services, or was yours a little bit more of a scheduled level?
So back at that time, it was outpatient services that were done in the home, and so it was a much higher level of care than you would see when we think about outpatient counseling. You know, we think about a counselor that comes and you go to their office 1 hour a week. We would be in the homes with these children and their families for 20 to 25 hours per week.
Woo!
So it was an incredibly high level of care, basically the level right below residential or inpatient services, trying to keep children and adolescents in their homes, in their communities. And so although it was scheduled, it was very intensive. But I also was a certified pre-screener, and so I would do what we call pre-admission screenings for emergency custody orders and temporary detention orders, which are involuntary psychiatric hospitalizations, and I've done them for adults, but adolescents and children as well.
Awesome. You know, it's interesting to know, too, you know, what kinds of, are the conditions that would get a child or, you know, minor into involuntary commitment, are they the similar kinds of disorders you would see with adults and why they would need to go to involuntary commitment?
Mm-hmm. That's such a good question, and the interesting answer is the criteria for an ECO or a TDO is exactly the same for children and adults. It's either that the individual is a threat to themselves, a threat to others, or they're lacking capacity to either meet their basic human needs or to make treatment decisions for themselves. And so it's interesting that although, as I'm sure we'll get into, there is a world of a difference between adolescents and adults in terms of how the same diagnosis, the same symptoms can present so differently, that criteria is exactly the same.
Yeah, that's definitely very interesting to me, and that's why I'm really excited to talk about this, because again, like, you hear about adults all the time, but you never really talk about like pediatric mental health. So that is very interesting.
Oh.
Miss Renee, would you like to introduce yourself next?
Well, hello, my name is Renee. I am Hannah's mother, and I am a student at Giles Technical College, and we are have been doing our project here, behavioral health in the adolescent age. We came about this project, about 6 months ago. We decided on this project because we kind of felt like there's such a big need for it now. Like friend over here said, I know your name, but I'll call you friend because Hannah calls you friend too. Yeah. But, there's a lot for adults, but what do we do with our children? And who do our children go to when they do need the help? They have to go to the family, So, yeah, it's a really need for that. I believe there's a big need for hospitals, like state hospitals.
Agreed.
We have one that's located I believe it's in the upper portion of Virginia. That's the only mental hospital I can think of for adolescents in this area, which I know NRVCS, which I do work for NRVCS too. I know that they do have programs and outlets there too. But as for my whole big thing was the just having the mental state hospitals these children can go to get themselves right or what they need, the care they need.
So to clarify, you're not talking about Catawba or Marion, right?
No, I'm not talking about Catawba or Marion. Megan, do you remember the name of the hospital up there?
It's in Staten, Virginia.
It's in Staten, Virginia. We were going to go up there and take a trip, but it's kind of a long way. But
So let me ask you, Mom, and not to call you out, but me and you kind of have this in common. Mom, I think, is where I kind of got this mentality at, but Mom and I are big people that say you are a reflection of how you were raised.
That is correct, Hannah.
As I've gotten older, I have seen, especially in the line of work that I do, I do work as a nurse at the jail, as many of you know, but I do think a majority of them got to where they are because behavior wasn't corrected when they were younger, but I can't say that for everybody, though. I can't tell you how many times I've genuinely got phone calls from concerned family members, and they tell me some about the patient's background and how they grew up, and it's quite sad. And sometimes through those conversations, you can find out that, hey, that might not necessarily be true. There might be some exceptions to that rule. So I was curious to know if your studies in this field have changed your mind about that at all, as they've done mine.
It has at a point, but I do believe a lot of times it does start with the family. It does start with home life. Not putting a blame on that or, pointing it out, but I believe it's a foundation from how you're raised to an adulthood. But I also agree with you too. I think there may be medical conditions that may be the issue too. Chemical imbalances, and they've come out a lot in the last few years about chemical imbalances and things like that. But yeah, I agree with you on that too. I do believe that is like the ground spot. That's where it starts. Mm-hmm. And I'm not saying that, everybody has trials that they went through when they were children and adults now, but...
that's important to say because everybody has trauma. Literally, everybody has trauma. Everybody has a story.
And I think it's just the way that maybe you handle the trauma. Mm-hmm. And just having those outlets and that place to go, or whether it be medication, therapy, or anything like that, having that available to the younger generation, I think that would be a big help.
For sure. Miss Megan, would you like to introduce yourself and tell us a little bit about your background?
Yeah. Hello, I'm Megan. I work at Warm Hearth. I'm a CNA and an RMA. I also go to Giles High School Technology Center to become an LPN. We picked the mental health awareness topic well, there was a lot of reasons why we chose this topic. We chose it because of the cost. We chose it because of the awareness. People aren't even aware that there's a problem with it. We also chose because there's lack of facilities. There's also lack of resources. In order to find help, you have to kind of like Google and try to ask friends and family to help you, to try to lead you where to go.
Yeah, I know that if there was ever a crisis with babies, I would probably be like, Alexis, help, what do I do?
Friend,
Exactly.
get on over here.
But I think you're right about that because, like I've said probably 500 times now, like you hear all about, you know what to do as an adult. You know,
Right.
there's all kinds of, you could go into doesn't NRVCS have walk-in clinics you can go to? I mean, you can do that for adults, but you don't hear about that being an option for kids.
Right.
And too, Hannah, nowadays, don't you hear so much of school shootings now?
Yes.
These young children. Now, we didn't hear much of it back in the 80s. Well, I don't want to say my age. But when we were growing up, I mean, we didn't hear of school shootings very, very rarely. And now it just seems like it's every other month we're having these awful shootings. I mean, the last one in particular, young 15-year-old girl, it's just like how...
I heard about that.
How, where were the signs at? Was she able to talk to her parents? Did she have somebody to talk to about what was going on with her while she decided to go that route? I feel like we need clinics. We need places where these children can go until it escalates and to that kind of point, Yeah, I mean, that's kind of how I feel about that.
Mm-hmm. Megan, you mentioned really quick side topic that you worked at Warm Hearth. Do you work at Cronjay Center, Showalter?
Showalter.
I went to Showalter when I was working with Warm Hearth at home, and that place is like a hotel.
It is. It's really nice.
It's a fancy hotel.
Yeah, it's assisted living. It's really nice.
Is that where the lady is we used to visit?
No, she lived in another assisted living part into Warm Hearth. But yeah, I think everyone makes really valid points about why pediatric mental health is just so important. I wonder, I don't know if you guys would agree, but if we had more resources to address these things at an early age, therefore that would create a domino effect. Would cut back on the people incarcerated, which, has the inmates and they get pissed off. Well, I'm the reason you have a job. Well, that may be true, but also, I don't want to see y'all in here. I want to see people do good for themselves.
Right.
If we had those resources now, we can cut back on that. If we had those resources to start addressing this early on, it might cut back on the level of people addicted to drugs who go to substances. Because from what I've seen, again, I'm not the mental health professional, but people who are abusers, they are using that to cover and fill a void that they have issues that they have not had addressed. And if we made more resources available, I really think that would help with that.
I totally agree with that, Hannah, but I also think a lot of the problem, too, is the cost. How do these families afford having their children go through sometimes intense therapy? Insurance, even having insurance nowadays, it's very pricey. And you think about the families who can't afford insurance and still have to go through this, and it's. I just feel like, and I know it's hard to fund, and all of our states are the way they are, but sometimes you wish, let's cut something back and let's get more funding in our states and to help these young individuals, get on path or get the problem solved and all that stuff.
I totally agree with that.
I do too, and I think that you, Renee, and Hannah both spoke about early intervention, and it, I think, is such a double-edged sword when we think about the age in which a lot of these traumas, these mental health symptoms are coming up for our children and our adolescents, because they're happening at such critical periods in their development. And so the effect they can have on them is, it cannot be overstated. And on the other side of that coin, the importance of that early intervention during that same critical period of development can go so far in mitigating some of the risks, some of the consequences of these experiences. And I think everyone has made such a good point that there's no singular cause, to mental health issues in this population. I don't know if you all have ever heard, back in the day, people used to debate nature versus nurture.
Yes.
What was the cause? And I think our current understanding is it's nature and nurture.
And that makes sense.
That it could be genetic predispositions to certain diagnoses, to certain symptoms, chemical imbalances, and it could be contributed to their environment. They've done many twin studies. You take a set of twins, they're separated at birth, so genetically identical, and place them in different homes. And studies have shown time and time again that although genetically they are identical, they start with the same biological foundation, that the impact on their environment is pronounced in a myriad of ways throughout their life. And so I think that it's such a consideration when we think about expanding access, securing funding, because no greater time to provide and wrap these children and these teens up in services than now.
Correct.
Well, friend, and you have to think about it. These kids are our future.
Mm-hmm. They sound like the jail administration with these new officers. Sorry. They are the future of this jail.
They are. I mean, our children, our adolescents, they're our future. They're who's going to be running the country the next, few years or whatever. Mm-hmm. And yeah, I mean, I think we need to make that road pay for them, mentally or whatever we need to do. Definitely.
Mm-hmm. Alexis, I have to bring this up because we were just talking about this patient the other day, but I've known sometimes, I'm going to be honest about it, I can sometimes lack compassion with mental health at times, but this one patient in particular we have at the jail.
Trust me, I can too.
I've said many times that the problem with her is that she just needed her ass beat when she was younger, and it never happened. But hearing Alexis and our other mental health clinician, other Alexis, talk more about it, there's more to it than just that. It seems like this patient does have diagnoses, does have things that she actually can't help, even though it's really hard because, and I'm sure we do see this in pediatric population, but her in particular, her outbursts and stuff, they seem like they're behavior induced. And sometimes it can be really challenging to tell the difference between someone who is just behaviorally acting out or someone who legit has a problem. And I think for me personally, I will fully take blame that I'm guilty of having that stigma sometimes and an inability to differentiate between that. But maybe that's another reason why we don't hear people talk about it a lot. It's because people just say, oh, there's nothing wrong with that kid. They just need their ass beat. And, just like with children in school who have ADHD, I'm not saying anything against medicating them. I'm not. But I am saying that it may not be right for every child. And where's the line? Again, I'm not the expert. Where's the line between a kid just being a kid and someone just wanting to dope a kid up and zombify them?
Well, too, going back to the whooping the child's ass or whatever. Now, Hannah Renee, she was never spanked as a child, and I am a believer of spankings if she needed one, but she was the type of child that did not require spankings. Her way of punishment was if, say for instance, she did something and I was very displeased of what she done. All I would have to say to her is, Hannah, Mommy does not like what you just did. And she would break down. I mean, that was her punishment. She didn't need spankings. She didn't need things like that.
Well, that kind of goes into what I was saying about what works for one child may not work for every child.
Work for another. Absolutely. And then she would go to me, and of course, I would talk to her about it, but it was always, Mommy told me. And she'd go tell my mom all the time, Mommy told me. But I think that I've raised a pretty good girl over here. And she's a very good mother herself. So, yeah, I mean, I totally don't condone violence or spankings, but I wasn't against it either when she was a child.
I think you all bring up a really good point, and I think that it can be difficult, to Hannah's point, when we see adults behaving in certain ways to think, oh, they're just doing that for attention, as we often do with children. And I said to Hannah the other day, my supervisor during my residency said, what if we replace the word attention with connection? They're not attention seeking, they're connection seeking. They're reaching out to you. And I think all behavior is a form of communication, especially with children and adolescents. They may be behaving in a certain way to get their needs met, whether it's to communicate, it's sensory seeking behavior, or perhaps it's trying to escape a demand that's maybe too difficult or is stressful for them. And I think that understanding that can go such a long way. And I think often that what happens with pediatric and adolescent mental health services is that even though the child is the identified client, the family is hurting.
Absolutely.
And one case that I had comes to mind. It was my very first intensive in-home case I ever had. It was an 11-year-old boy, and he was the identified client, had a diagnosis of ADHD, had a lot of conduct issues, some oppositional defiance. And when I got to the home, his parents, mother, stepfather, were both ready to tell me, he does X, Y, and Z, and he's the issue, and he's causing problems. Not in those words,
but essentially,
but that was the sentiment. And the longer I was in the home, became so clear that this boy was just the lightning rod for all the dysfunction in that home. There had been such a trauma that occurred, and one of the younger siblings had an accident, received a TBI while the father was home. So you think father's racked with guilt. That's manifesting for him as anger, frustration, short-temperedness with all the children. Then you have the mom who is so anxious. She can hardly let her youngest daughter who received the TBI out of her sight. And so you take a step back and you look at everything that's happening in this home.
Like the whole picture.
Yeah, and you see...
Yeah, I think you need to look at that whole picture.
Yeah,
exactly.
Absolutely. Because it changes everything.
Right.
And, we say, of course, there's supports needed for this boy, but everybody in this home needs help.
Right.
Everybody in this home needs support. And I think that's the beauty of home-based services, is there's always parent goals. I've worked with several families where multiple children are in tandem services, because we need to see these children in these environments where these behaviors are occurring. Because how can we understand why they're happening? What's reinforcing them? Unless we're seeing it in real time.
Man, that's spot on.
Now, friend, don't you think though that the family should be counseled just as much as the child itself? Because it seems to me that's who they're going to have to go to when they're having the issues. And if they don't feel safe, and just like you said, the mother with the high anxiety, I've known adults that would not go to their parent with high anxiety. They would just rather keep it to themselves, or use another outlet for their behavior. Do you think maybe having the resources, even for the families of these children, would help in that aspect?
Oh, undoubtedly. I mean, if you think about it, children and adolescents do the best when they're surrounded by the widest circle of love and support possible. And so how could we possibly support the child if we're not supporting the family that they live in? And so we always had parent goals as a part of our treatment plans. And a lot of times, even if the parents were hesitant about seeking their own services, we'd always want them to know what services are available for them, what supports could be in place for them, and how by helping themselves they can by extension help their child. And so I remember one evening very clearly, father had a disproportionate reaction to something that happened at dinner, became very elevated, very escalated, and my client followed suit.
Learning just from what he sees.
Absolutely. And so, and it's not about shaming the parent. It's about helping them understand that social learning is the most powerful form of learning that exists, especially for children. They're like sponges. They soak up everything in their environment, everything, especially that their parents say and do. And so I said to them, how can we ask our client to do something that we ourselves as the adults in his life are not willing to do.
Yep.
And I think that really helps shift their perspective, that even if they didn't necessarily want to change their behavior for their sake, they wanted to do it for their sons. And so the child really can be a catalyst to healing, I think, for the whole family when you can get that buy-in.
Absolutely.
I know me personally, like, with Mavis, I recognize that I have a short fuse. It's something, I'm not going to completely blame genetics, but I have a short fuse, and that runs rampantly in my dad's side of the family. But I don't like it, and I don't like when I think about the levels of violence and aggression and anger that I was exposed to as a child. I always said when I became a mother, I would never do that to my child. So I know that part of ensuring that Mavis does not get exposed to that, I have to look at myself and think of how I react in certain situations, and I have to make a conscious effort. And let me tell you, it is damn hard, but a conscious effort not to lose my shit on certain things. Because I don't want Mavis to see that. I don't want her to learn that behavior. I don't want her to see that, that it's okay to act like this when you get mad. Because I will fully admit, sometimes I get really, like, to a level 10 over things that are like a 2. But yeah, I agree. Like, you have to look at the whole, family unit, because children, like you said earlier, they're sponges. They don't know any better. They're just learning based off what you show them how to do. So I think that probably is the case in most of our pediatric population who have mental health struggles, is that, not every single pediatric patient, but it probably does stem a lot from what environment that they're in. And if their genetics are predisposed to certain things, that, just makes it spiral out of control probably.
Absolutely.
Do you have any children, Megan?
No, I don't have any kids.
Do you have, like, any family members who have children that have ever had, like, struggles mentally, or friends?
Both of my sisters have kids, but I mean, besides the normal struggles, like not doing their homework, simple stuff like that, not anything big.
Well, that's actually a good point, because it kind of leads me into another question. How do you differentiate from what's normal children just being, their normal defiant selves, and we have a problem here?
I think that's such a good question, because I think it's such a fine line between minimizing or ignoring symptoms of perhaps what could be a more serious mental health issue, and over pathologizing normal child and adolescent behavior. And I think what really helps, at least me as a professional, make that differentiation is when we look in the DSM, the Diagnostic and Statistical Manual of Mental Health Disorders, every diagnostic criteria, it doesn't matter what the diagnosis is, it has to cause the client significant functional impairment. And so, a child not doing their homework, that is something that you'd be hard pressed, I have no doubt. You'd find it in every household in some way, shape, form, or fashion. But when we think about a child, for example, who maybe is so defiant that they're not bathing, maybe they're not eating, then we start to look at, this is not what we would consider kind of within normal limits of, the defiance that we all had as children. And it's starting to impair them in different aspects of their life. It's inhibiting their ability to care for themselves. It's, causing deficits in their ability to socially engage with others. And I think that that's really where we start to see, okay, I think that there's some support needed here outside of what's already being provided within the home.
Absolutely.
Alexis, how much do you think an involvement in pediatric mental health is from peers? If we go, like, outside the family unit, what about when they get to school and, there's cases of being bullied, or they're just learning from other people? How much do you think that has an effect on the fact that, if they do have struggles, how much that contributes to it spiraling?
I think it can be immensely so. I mean, we go back to our social learning, they don't just learn from parents, they learn from their peers, their teachers, their community helpers. I mean, they learn from everyone that they come into contact with. And you think when they're school age, I mean, that's where they spend the majority of their day, 5 days a week. And so that shift is that they're not in the home with their family of origin, all day, every day. They're at school where, like you said, they're exposed to all different kinds of people and situations. And I think it can be difficult, especially when you're working with children, is to have that consistency across environments when it comes to providing different kinds of supports or having specific like behavior interventions in place. Because I've worked with children where we could see behaviors that are only happening at school. They don't happen in the home. And so the parents may want to say, minimize that behavior because they say, oh, it doesn't happen here. It's only happening at school. Or, you know, you can see the total opposite where it's happening at school, in the community, you know, everywhere that the child goes. And so having the people in the child and the adolescent's life all involved in their treatment, because it truly, they say it takes a village, and I wholeheartedly believe that. I think when you're trying, especially when you think about children and adolescents who struggle with, you know, severe and persistent mental illness, they need support in every aspect of their life in order to maintain these gains that they make in treatment, especially if they're happening on a much lower level of care. I mean, I would work with families sometimes for several years at a time.
Wow.
You know, and I mean, we're providing, like I mentioned earlier, intensive levels of treatment, you know, anywhere. I think our lowest number of hours per week would be 10. So 10 to 25 hours a week with families, you know, and gradually those services would reduce over time as they got ready for discharge. But you think about how could you make progress with children that are only receiving 1 to 2 hours of treatment per week? How can we make progress when they're only working on those skills, they're only practicing them in the therapy room, and they're not generalizing them to the environments where the behaviors are occurring in the first place?
Yeah, I feel like as a parent, what would be one of the really frustrating parts, like, you know, if Mavis goes to school, and I hope it doesn't happen, but realistically, there's a high possibility she gets bullied. And then I know that there's a lot of parents out there that know their children are being bullied. They try to speak up. They try to take the proper steps and say, hey, you know, I need to speak to the principal. I need to let them know what's going on. And it would be so hard for me as a parent if someone else's kid was affecting my child's mental health and nothing changed about it. That would be so freaking frustrating. Like, I would want to smack a bitch.
Didn't we have an issue with you when you were in middle school with bullying? And old Mama Bear here stepped in,
Yes.
of course.
I was, and I'm sure this is the case for a lot of kids, but I was bullied the heaviest in middle school. You name it, practically, it probably was done to me. But I remember specifically, this was actually before I got into middle school. I think I was like in 5th grade. Or no, I might have been in 6th grade, actually. So then I would have been in middle school. Also, disclaimer, you know, I'm not saying anything like offensive here. I'm just saying, like, I grew up in Greensboro, North Carolina. That was a highly populated area. You saw a lot of different, you know, peoples of race, ethnicity, social status, financial status. I mean, you had a mixture of everything. So there was a lot of diversity there. But having said that, there was a lot of neighborhoods nearby where lower income families, and you just have to take into consideration that, because you just wonder, you know, what kind of stresses those children might have been exposed to growing up. Or if their families had time to, you know, properly explain to them, like, hey, this is not okay to do that. You know, you just never know. But I was taking the bus home from school one day, and you know me and my mouth sometimes. We were riding the bus home, and there was a couple girls on the bus, and one of them was just screaming at everybody to shut up, shut up, shut up. I don't know why. I mean, I wasn't even talking. It literally was not about me whatsoever, but I don't know why. I just spoke up, and I was like, you are not the boss, or I said something like that. I mean, I was in 5th or 6th grade, you know, as a kid. Their stop was before my stop, and I guess the girl and her friend didn't like that I said that. And on the way down the aisle to get off the bus, one of the friends poured an entire bottle of water on top of my head and humiliated me in front of everybody and said, nobody talks to my friend like that. I was really upset, and it was embarrassing to me, but also, you know, the fact that someone, you know, at this point in my existence in life, so mean that somebody could do something like that. And I remember I was very upset, and I came home, and I was, you know, soaked head to toe, and I was crying to Mom, and Mom was pissed.
Yeah, I did end up calling the school and explained to them what happened and that it better not happen again. And they kind of played around a little bit. You know, they they didn't, I don't really want to say they wanted to accept the responsibility of it, but I kind of felt like they were trying not to. And I had just got at that point, I said, I am a working mother, single mother. I have to have transportation for my daughter to go to school back and forth. And she should feel safe doing this. And I do remember standing up, but I kind of felt like, again, it was kind of like a roadblock. So I just ended up picking her up from school and taking her to school. I felt like that was the only right to do that, being her mother, because I didn't want to see her go through that at all.
And that was a huge relief to me. But I did find out that the girls who did that, they both got suspended from the bus for doing that. But I think about it now as an adult, looking back. What kind of strain did that put on their families? Mm-hmm. You know, if they couldn't ride the bus and their families weren't available to take them to school, how did that work out?
Not only did it negatively affected you, like you said, how did it negatively affect their family and them too? Right.
So, when we see issues, that was probably just an example of typical bullying. But, it just makes you think. Like, it's just, I think everything is a domino effect.
Mm-hmm.
Yeah, there's just so much to this pediatric mental health stuff and all these different things that we're thinking of as we talk about it, how it just dominoes and affects not only just outside of families, but just even as they grow up too. But Alexis, do you know at the top of your head, like, how many pediatrics population, like, has mental health issues or have a need for mental health services?
So I would say I think it's far more prevalent than we could ever anticipate. I know, and this was quite some time ago, but the last number I saw was the U.S. Department of Health had released their most recent census from 2023, and it said 1 in 5 children or adolescents between the ages of 3 to 17 had some type of mental, emotional, behavioral, developmental disorder.
3? My gosh. Makes you wonder, like, a 3-year-old having mental health issues. What? Oh my gosh, I wonder what that would look like. I hope I don't, have to find that out for myself. But, is it easier for pediatric population to get into, like, an outpatient or an inpatient setting than it is an adolescent or an adult?
I would say I don't know if anyone would think that the opposite was true, that it is easier, but I find that it's actually much more difficult. When I was a certified pre-screener and we were doing bed searches, if a child or an adolescent was going to be ECO'd or TDO'd, the list of psychiatric hospitals that will accept children and adolescents is already initially far less than adults. But a lot of hospitals have exclusionary criteria. Like, for example, a very common one is that any kind of developmental or intellectual disability, like autism spectrum disorder, for example, could be exclusionary.
Wow.
Or if children can't or adolescents can't engage in activities of daily living, like bathing, hand washing, teeth brushing independently, they won't take them. A lot of times, any child or adolescent who has, like, some type of assistive device, like a cane, a walker, a wheelchair, the hospital won't take them. And so it's difficult to see that even at the highest level of care, there are so many barriers that exist structurally, let alone, like you and Renee had mentioned earlier, the barriers that can exist with funding, transportation, time. And then when you think about how that compounds with the internal barriers that can exist, children and adolescents, I think it takes a very skilled practitioner to provide them services that are developmentally appropriate for them, that they can engage with. Or when you think about your adolescents, their readiness and their willingness to engage, I think that sometimes we can overlook how difficult it can be, especially at such tender ages, to even come to terms with the fact that you're struggling, let alone what you have to do when you're the recipient of these services in order to benefit from them. It's a huge ask for such little people.
And what's crazy to me is the fact that they won't take certain pediatric patients because they don't know how to do ADLs. Some of these patients are children. They're still learning how to do these things. But yet, we'll take adults who, normally speaking, should know how to do these things. Like, that is just crazy to me. Do you agree or disagree that criteria needs to be changed for pediatric population?
I think that it doesn't necessarily need to be changed, but I think that it needs to account for the nuance that exists between children and adults. Because although I think that we are far more similar than we like to think with children and adolescents as adults, I think that there are some really unique considerations for their treatment. And it's interesting that the exclusionary criteria is actually similar amongst children and adolescents and adults. And so it's interesting to your point that when you take into consideration just their developmental age, their like independent skills could just not be developmentally appropriate at that age, not necessarily as a result of any kind of mental health or psychiatric issue that they're having. And so it's a very sobering thought to think that resources are not only so limited in terms of their quantity, but that there are so many barriers and flaws that exist within our system inherently as well.
Mm-hmm. Yeah, I totally agree with that. You and Mom both mentioned, which, well, I know this, of course, but you both work for NRBCS. And Alexis, you are in the jail with me, so we see a different kind of environment than Mom does, where she is... she works at Fairview Home with patients who mostly struggle with IADL type of activity. But I was curious to know, because Mom has mentioned she's, of course, heard me talk about certain work stories with the kind of people that we sometimes have to deal with. And my mom's like, well, it's funny you say that, because I'm telling you, some people at my job could be just like that. But I was just kind of curious to know, Mom, from your end, what kind of patients do you work with? Do you work with adolescents? Are they mostly adults?
Most are young, or there are a population of elderly adults, middle age, and I don't think we have any that's below the age of 18. We've had a couple that have been fairly young there, which they don't go there anymore, but it is, to me, sad that especially there's a couple there now. They're young ladies that I kind of feel like with the proper guidance and the help maybe earlier in life. And like I said, I don't know what goes on in their home lives and how they were raised and stuff like that and how they were brought up. But I kind of felt like, and I'm not saying where I work at is a bad place. I think it's a wonderful place to transition into the community. But it's sad that they have been there so long. These ladies should be out getting educated. They should be out in the world working. And because their limitations, they have mental health issues, but they are controlled by medication. And I honestly, I don't see why there would be a problem them not getting out into the real world and being able to do things for themselves and have jobs and go back to school. I know one had came to me several months ago and she had said, I'm really thinking about taking a medical transcription class. I really want to do that. And, I just encouraged her. I really, in my mind, I'm thinking to myself, how could this happen? But then I thought too, she's got dreams. She's got goals just like anybody else. Just because she's fighting a mental health issue does not mean that she can't be part of our, the society and be just like everybody else. So I do see that some, not very often, but I have seen that. And that is sad. That is sad.
One thing that definitely is different where we're at, you said that there's, patients that have potential to get to a point where they can be independent on their own, be functioning in society. Me and Alexis kind of see more of a population that, unfortunately, it's just repeated behaviors because a lot of them, it's all they ever know. So we finally brought back the GED classes and the AA classes. Now we have Miss Johnson coming in and she's doing baptisms now. And I'm really happy to see that. But, before COVID hit, we had a lot of programs to help rehabilitate. And we did away with that for a while due to COVID. And now we're starting back up with that again, which I really, really like. One thing I'd love to see back, if ever possible, at one point in time, we were having a program called Empowered Options, where the health department would come in and do some free sex education courses to the women. and they would do, I believe it was the Nexplanon. I can't remember if it's Nexplanon or IUD, but free birth control for women, so that they have more access to control their lives. Yeah, but generally speaking, though, where we're at, it's sad, but, some people are inmates who come in one time and you don't see them ever again. But unfortunately, a lot of them, you see them come in and out all the time. And that's just all they've ever really known.
Yeah, and just like I was saying about the younger people, and I've seen them. They'll go out in the community, but they'll go to a recovery center, and they have games and stuff like that. I understand that, but I wish they had like a program for the younger ones. Like I have one resident that loves photography. Get her in a photography class, or any kind of thing that triggers them in a positive direction. I know that the state's not fully funded with a bunch of money, but I think this would really help them, certain ones, that are young, like these young ladies that I have. Put them in classes like that. Put them in a medical transcription class. I'm sure it's not that much. I mean...
Well, I got to point out, this isn't the same level at all, but I do remember when I was in nursing school, I went to Fairview Home for my mental health clinicals, and I had so much fun at Fairview. I mean, it was a type of environment where I literally just played Uno with them, just talked to them, hung out with them and had fun, and I enjoyed that so much.
They do. They love that, and that's the majority of the clients that I have there. What I was speaking to you guys about is just a couple that are young ladies that probably should be out in the community and doing things. But yeah, they're very innocent, very loving, very childlike. They really are. But then you have the issues too. They can be very manipulating. They can lie to.
Definitely see that when we work.
Yeah. I mean, that's what me and you have talked about. Like, you see a lot of manipulation in the jail system. Well, I see a lot of manipulation where I'm at too. But, you can't cross that line.
It makes you wonder if there was perhaps an issue during their younger lives where...
Absolutely.
Where issues weren't addressed and it has spiraled. Just makes you wonder.
Absolutely. And I think that because I think about these two young women particularly that I'm talking about. I met their families before. I haven't met one of their family members, but the other one I have. And so much like, have you ever heard the apple don't fall too far from the tree?
Yes.
That's kind of how I was getting this picture. And in the other situation, I think the mother, I've never met her, but just had heard things. I felt like maybe the child was controlled a lot in her life, was not able to make decisions on her own, that the mother was there to make the decisions for her all the time. And then, it affected her when she got to be an adult.
I think that kind of goes back to what Alexis was saying earlier, is that it is a whole family unit type of thing. Like, it's not just the kid, it's the whole family needs to be on the same page with things and also receive treatment for services and learn how to redo certain things. And I think that is a prime example of what Alexis was talking about right there.
Absolutely.
Well, it's funny you mentioned that because you guys know how I love to read all the time. There's actually, it won the Goodreads 2024 award for Best Nonfiction Book. I can't remember what it was called, but it is essentially about why, I'm considered a millennial, but why people in my age group have more of mental health issues. I haven't read the book, but from the synopsis I got from it, a lot of it is actually being blamed on increasing screen time. I don't know if I would necessarily agree with everything in that book, but there are different theories, out there, and that was just interesting that was one of the things mentioned as to why.
All these electrical things and all that stuff. I mean, back then, we went outside and played. Mom said, go play, and I can remember sitting on my porch with my neighbor and playing Barbie dolls all day long. Right. We had Barbie houses and castles, but like when you're your age, is when all the electronics started, and I'm not blaming it on that, social media and things like that. I think that is an issue, though. It could be.
I think there's a lot of aspects to it, but yeah, if I ever check out that book, I'll let you guys know what I think.
Yeah.
Kind of switching over to me and Alexis, I was going to ask you, Alexis, we see a wide range of mental health issues. I would say, even though I'm a correctional nurse, honestly, I feel sometimes like I'm a mental health nurse, even though Alexis will hear me say all throughout the days, I'm not a mental health person. But there's so many patients who have mental health needs where we work at. But Alexis, do you remember there's several patients I can recall being like the most challenging to deal with because of their mental health issues. There was one in particular that to this day was the worst inmate I've ever had to deal with. And that may just be biased at this point now, but her diagnosis was borderline personality disorder. And her behaviors were very attention seeking. And I remember I constantly, honestly, I felt like I lost all compassion for her because she would be in and out of the restraint chair all the time. She would do self-harm behaviors, but she'd be the type to put a plastic knife on her across her wrist, say, oh, I'm cutting myself. And, all the resources that had to go to dealing with her, I remember I would be frustrated so much. And I was interested to know, do you have much experience with borderline personality disorder?
I would say that there's perhaps a misconception that personality disorders are the kind of most common diagnosis that we see in our setting. But I think to your point, we see such a wide variety, whether it's mood disorders, it's personality disorders, it's intellectual developmental disability disorders. And I think another layer to the onion, so to say, is that a lot of these diagnoses are what we call co-occurring, and so a lot of times it's a mental health diagnosis with a substance use diagnosis. And so I think that sometimes that can contribute to the presentations that we see. And I think what can be so difficult to remember is, like you said, it's our kind of almost gut natural reaction when we see an adult engaging in behaviors like what you described to say, gosh, that's such attention-seeking behavior, that's so behaviorally motivated. And it's hard to picture, when you're looking at the grown woman before you, to think about the little girl where those behaviors probably originated in the first place.
You're right.
And I think that it can be so difficult to, like you said, maintain that compassion, continue to give that empathy. But I think that when you picture her, especially in our population, I'll never forget it. When I was an intern at another regional jail when I was still in my master's degree, the very first intake assessment I did, I was doing a substance use history. And one of the questions that we ask is age of first use for each substance that reported. And I asked her, I said, how old were you when you used meth for the first time? And she said, my mom shot me up when I was 6.
Oh my gosh.
And so you think about someone like that and your heart breaks.
That is sad.
And it's hard to remember that when you're seeing the manifestations of this trauma, of that dysfunctional environment in adulthood. But I'm a firm believer, I think people learn how to get their needs met, whether that's in a healthy or an unhealthy way. And I think what can be so difficult is that just because something is healthier, just because something is more productive, it's unfamiliar and therefore it can be uncomfortable. And so I think it can be really difficult, especially for when we meet these, what were children and adolescents in adulthood. They've been engaging in these behaviors, stuck in these cycles for years and years and years. And so I think what can be difficult but can be so worthwhile is showing them that there are other ways to get your needs met. Even though it may seem counterintuitive at that age, it's so necessary. And I think going back to the conversation you and your mom were having earlier about engaging with clients of any age in these individual and social leisure activities, talking with them about their interests, their passions. I think that sometimes what can contribute to these cycles is that whether we think about children and adolescents who are in treatment, or we think about them as adults, whether it's in assisted living, it's in incarcerated settings, sometimes their status as a patient, as someone who has mental health issues, or as someone who has involvement in the legal system, can feel like the most salient thing about them. Because it's all anybody ever wants to talk about. We think about children, we say, oh, he's a problem child. She's a bad kid. And when we plant those seeds, you know, in their minds and in their hearts, how do we expect them to uproot that and replant it with something more kind, more compassionate? And although I think I use, you know, a wide variety of interventions with clients, whether it be
You do.
children and adolescents or with adults in our current setting, I think one of the most important things you can do across the lifespan is honor their humanity. Remind them that there's so much more to them than just their mental health issues, just their status as someone who's in inpatient treatment or someone who's incarcerated. Because I think that when you communicate to them, both directly and indirectly, that they have the opportunity to grow and change and be different, that can be the biggest catalyst to any change you could ever see. I'm realizing now in retrospect that doesn't answer your question at all.
That's I've been so fascinated, I've not even like noticed at all. No, seriously, that's such a good point, because honestly, like, you have inspired me to try to think about that the next time someone is pissing me off.
Exactly. When I'm about to lose it, I'm going to think a friend over here, what she said, and I'm going to step back a minute, because she's right. I mean, these individuals have been putting probably up with this behavior and this, and for years and years being treated, and you know, we don't know what they went through all their childhood and stuff, and they've had to endure it all these years, and we're just getting what they are now, you know?
Yeah, I was going to ask you too, just really quick, if you ever remembered, this man came into our jail and he literally identified as a baby and wanted to be treated as a baby. And I remember we had to give him Depends because he would use the bathroom on himself. And he wanted, I can't remember, there's some other things. I struggled so badly to just accommodate to that. It was so hard. And I'm thinking, what in the hell? What? If you're acting like a baby, how are you in jail? And what is going on here? Do you remember that, man?
I think that although an anomaly in terms of presentation, it really makes sense to a degree when you think about not necessarily the behaviors, but what's underneath of that. Because if you think about childhood, you know, what do you think about? You think about safety. You think about some ease of mind, you know, and it makes sense that if someone is in a situation that they are not equipped to handle, to navigate, that they would revert back to a time where they felt all the things that they don't currently. And although, like I said, I think that that presentation was unique, I think we see it probably in all of our settings, that that's all people want. You know, I don't know if anyone is familiar with the idea of Maslow's hierarchy of needs.
Yes.
But you know,
learned it, didn't we?
the bottom of the pyramid is safety.
Safety.
Without that, I mean, how can you advance? How can you progress? And I think that can be the common denominator. And I don't just mean physical safety. You know, emotional safety, I think, is something that a lot of people can lack from, you know, the time they can walk.
Yeah.
Yeah, I guess Hannah can kind of say that. I mean, with our relationship, I feel like that is something as a single mother and a mother that I did provide for her. Safety. She was able to talk to me about anything without being judged and lectured. I mean, of course, she knew how I felt about things, and I would explain right and wrong to her. But I also gave her choices, too. You know, like you said, safety, that's the number one thing. I know she felt safe with me.
How can someone continue to develop if they cannot pass one level of the whole entire purpose of evolving into a person?
Well, I think you make such a good point about I get many questions of how did you go with working with children and adolescents in the home to working with adults in corrections?
I was going to ask that next.
You know, and it's so much more similar than you could imagine. I think because of the point you make, Hannah, we encounter almost an arrested development, especially when you think about how many of our folks were exposed to substance use at such young, formative ages. And one of the things that I think is so important is this could be potentially a controversial statement, But I am a firm believer that while we honor the ethics of our profession, adhere to our boundaries, I think that we have to love our clients. Because sometimes we're the only people that do.
Absolutely.
And I will never forget when I first started at the jail, I was speaking with a gentleman, and I say this to this day to every client I see as we're kind of wrapping up. I said to him, I said, well, remember, I was like, we're here for you. We care about you, okay? And he just broke. And he just started crying. And I, kind of sat with him in silence. And I said, tell me where those tears are coming from. And he said, it's been so long since somebody told me that.
Oh my gosh, that makes me want to cry.
And it has stuck with me. I mean, that was over 2 years ago now. And that stays with me because I think it speaks to, that this was a man who was in his mid-30s at the time. When was the last time he heard that? Was it since he was 3, 6, 10? And so I think that nurturing and cultivating that love for the people you work with, whether it's in providing the direct services, connecting them with resources, I think that truly, can be what really heals, is that someone in this world cares about them.
Yeah.
And I think often we see, especially when you think about children and teens who are in abusive or neglectful home environments, they think these are the people who are supposed to love me, who are supposed to care for me, and they're treating me this way. And so when you have someone in their life, no matter who it is, whether it's a teacher, it's, a community helper, it's a provider, someone who holds them in that regard, who, treats them so tenderly, who's responsive to their needs. That in and of itself, you can't even imagine the effect that can have, not only just on their mental health, but their overall self-perception as well, I think.
Yeah, I think that's a really, really good point. Well, guys, before we wrap up this discussion, which has been incredible, by the way, and very insightful, I must say, I did want to bring up a specific case that I don't know if you guys have ever heard about. Well, those who know me know that I love true crime stuff. And I remember when I was a kid, I saw this show. I think it was on A&E possibly, or I can't remember the network it was on, but it was called Kids Who Kill. And there's one case I have never forgotten. I can't even fully remember the kid's name, but I think it might have been Eric Smith or Eric Jones or something like that. He was a redheaded kid. He was 13 years old. This happened in 1980, and he murdered a 4-year-old. He basically, from what I know, I haven't studied extensively, but he basically lured him, sexually assaulted him, and then killed him in the woods. The body was found hours later, and he fessed up to it, but you see clips of this 13-year-old kid at the time, no remorse whatsoever.
I think I saw that.
The kid had no emotion at all. And again, I've not studied it extensively, but from what I know, he did not have a extremely traumatic upbringing. But like we said earlier, everyone has trauma. I wonder if something happened to him that just affected him in a wrong way and he spiraled. I don't know, but how common is it that you see children just have no emotion whatsoever? What could cause a child to do something like that?
I think my gut instinct goes to that although we can, I think, all acknowledge, especially in current day, that we all have experienced trauma in some way, shape, or form, that just because we've experienced trauma doesn't mean that we necessarily recognize it as trauma.
True.
And the reason why I say that is because, again, when I was in my internship at another regional jail, I was doing an intake assessment, and we asked very briefly, I say, you don't have to give me any details, but any history of sexual, physical, or emotional abuse. He said no. Later in the assessment, we're talking about sleep disturbance. I say, anything in particular keep you awake, nightmares, racing thoughts, anything like that? And he said, well, yeah, when I was 8, my brother was murdered in front of me.
Oh, God.
And that replays in my mind over and over. And see, we all recognize that immediately. We say, oh my gosh.
That's traumatic as hell.
How traumatic. He couldn't even conceptualize that as a trauma because it was one and yet a very long line he'd experienced throughout his childhood. And they say, what you don't know if you don't know what you don't know, it's a lot. And so you think if you have children who grow up in environments that are abusive, that are dysfunctional, they don't know anything else. And so it makes you wonder that even if there's the presence of trauma, how could there not be the recognition? And I also think in regards to, seeing a lack of empathy, I think that a lot of times across the lifespan, we see this kind of emotional blunting. You see this flat affect, you see individuals that are devoid of emotion, or to Renee's point earlier, we see anger. But I think that anger is like an iceberg. What we see on the surface of the water is just the tip of the iceberg. What we see is anger. But I think underneath that, lurking underneath the surface of the water, can be sadness, guilt, loneliness, disappointment. And it makes you wonder, going back to our point earlier, when we think about children and adolescents who engage in what we can't even fathom in terms of violence or aggression, how could that come to be? And I think the answer is that there's no singular cause. Just in the research I've done, and I don't think I've studied it as extensively as you, I read recently that they did a postmortem autopsy on a juvenile who had been sentenced to death, and the examiner said, that his brain was like Swiss cheese.
Oh my.
That there was such a lack of neurons in his brain, such a lack of so many fundamental connections. And you wonder, is that the reason why there was this engagement in such unprecedented violence? Does it reside in the family of origin? It's a difficult question to answer, and I think come to terms with as well.
Yeah, thanks for kind of diving into that a little bit with me. It's a very dark case. I need to show you more about it when we have more time. But I want to thank you guys all for being on the show today.
Well, we want to thank you, Hannah. We will be heading out to Richmond, and our people will enjoy this as much as we did.
Hopefully so, and I'm hoping that our numbers can go up and people can listen to this episode, and we can raise awareness for this topic. If you guys enjoyed what you heard today and would like to possibly hear part 2, we love doing multiple episodes on a topic, and just let us know. I also have a sister-in-law. She is I don't know the proper term, but she's a guidance counselor basically in the school system. I don't know if podcasts are her thing, but it would be cool to have her on the show and hear about what kinds of things that she has to go through in that setting.
And Aunt Kelly too, she's a social worker.
Right, my aunt is also a social worker. It would be awesome to have her on the show sometime to talk more about the things that she sees and deals with, which I know are very, very dark.
She is actually with the children. She takes a lot of the abused children and places them in homes and things like that.
Well, like I said, if you guys want to hear more, please just let us know. And again, I would like to thank Alexis, Renee, and Megan for coming on to the show today. Thank you guys.
Thank you for having us.
Yes.